going to present a short case. So this is a 47 years old female from Belur, presented with the complaints of vomiting for 1 month, blackish discoloration of the skin for the tanning of the skin for the past 1 month. So history of present illness, she was apparently doing well before 1 month. Then she developed vomiting, which is for past 1 month, 10 to 12 episodes per day, immediately after food intake, contains food particle, non-bile and non-blood stain. But there was no abdominal pain, no fever, no jaundice, no alteration in bowel habits, no loss of weight, no loss of appetite, no tinnitus or vertigo, no headache or blurring of vision or alteration in the sensorium. So her past history, she's a known case of hypothyroidism and on thyroxine supplementations. And there was a history of blood transfusion for 3 times in view of low hemoglobin, but not evaluated for the same. And she has a history of a recurrent spontaneous abortion in the past, which all abortions are less than 2 months. So when she came on examination, her vital signs, respiratory rate is 22 per minute, saturation is 98%, she was afebrile, and blood pressure is 80/60. Pulse rate is 84 per minute, her GCS is 15/50. So on examination, we have noted hyperpigmentation over the oral cavity and the knuckles. But all other systemic examinations were within the normal limit. Now, what is your diagnosis? Primary or second? We consider, we also in view of high suspicion of primary adrenal insufficiency and also patient presented with shock, we have sent the random cortisol and we started the patient on hydrocortisol. So random cortisol report came as 0.7. So under the electrolytes also showing sodium of 112, potassium of 6.1. So we confirmed our diagnosis of a primary adrenal insufficiency. Then we are planned to work up for the primary, because there was no history of exogenous steroid intake. So we are planned to work up for the same. So as per the Harrison protocol, whenever the patient is having primary adrenal insufficiency, we need ACTH, but the patient is already started on steroids, so we didn't send the ACTH level. And also for next step in evaluation of primary adrenal insufficiencies, to look for adrenal autoantibodies. But in our CMC, we are not performing adrenal autoantibodies, so we are planned to work up the patient in other way. So we have looked up the causes of the primary adrenal insufficiency, and we have planned to evaluate for the same. So the causes of primary adrenal insufficiency were, the first most common is autoimmune adrenalitis. Among this, isolated adrenal insufficiency, polyglandular autoimmune syndrome type 1 and type 2. Next common causes, infectious adrenalitis. Among this, tuberculosis, histoplasmosis, HIV infection, syphilis are the common causes. Third common is metastatic cancers, primarily from the lung, breast, stomach, colon cancers and lymphoma were considered. But the patient is having no history of fever, so adrenal hemorrhage is unlikely, and then there was no such drug history also. So we have done PET-CT to rule out the metastasis or infectious adrenalitis. But PET-CT showed no hyperactive metabolic uptake, and there is no evidence of infection also. PET-CT adrenal only revealed there was a small atrophied adrenal gland. And it also showed that there is a small heterogeneous thyroid gland, which is suggestive of probable diffuse thyroid disease. So coming back to our causes, we have ruled out infectious causes, we have ruled out in metastatic cause, and then the left one is autoimmune adrenalitis. But here this patient is in addition to adrenal gland involvement, there is some thyroid gland involvement, and that patient is also a known case of hypothyroidism and on medication. So among this list, we have considered the polyglandular autoimmune syndrome. So before coming back to my patient, I will just highlight on the polyglandular autoimmune syndrome. So this is a group of syndrome involving the group of endocrine glands. So here there are many types of autoimmune endocrine syndrome: type 1, type 2, and then immune dysfunction, polyendocrinopathy, X-linked, and then type 3 APS is also there, which is also called as Carpenter syndrome, and then POEMS, and then multiple pituitary hormone deficiency and Didmore syndromes. So I am going to highlight only on the type 1 and type 2 syndrome. So autoimmune polyendocrine syndrome type 1 and type 2. Type 1 is more, it's onset is in the young age, in the adolescence. Type 2 onset is around 30 to 40 years. In type 1, it will manifest in a severe way, more severe way, and in type 2, it manifests in a less severe way. Other differences are in type 1 and type 2, the common similarities, both will have a Addison disease, and then both have a Addison disease, both have a thyroid dysfunction in the form of either autoimmune thyroiditis or Graves' disease, or type 1 diabetes mellitus. But in type 1, in addition to these three parameters, patient may also have hypoparathyroidism and hypogonadism. But in a type 2, patient only have these three. Among Addison disease, Graves' disease, and type 1 diabetes, if any two of three antibodies is positive, then we will consider the diagnosis of autoimmune polyendocrine syndrome type 2. So these are the clinical presentation of APS type 2. So APS in APS type 2, the 50 to 70% people will have a primary adrenal insufficiency. 15 to 69% will have a Graves' disease or autoimmune thyroiditis. 40 to 50% will have type 1 diabetes mellitus, followed by primary hypogonadism. Other frequently associated autoimmune conditions were celiac disease, but celiac disease is very more common if the patient develops disease less than 20 years. Then myasthenia gravis, vitiligo, alopecia, serositis, pernicious anemia, osteopenia, and primary ovarian insufficiency. And there are many articles have stated that initially the most common, the patient will develop ovarian insufficiency, followed by which the patient will develop adrenal insufficiency along with the thyroid or diabetes, and followed by which the few years, like 2 to 3 years, the patient may develop other autoimmune associated diseases. So the recommendation is, whenever we are suspecting APS, these are the recommendation screening antibiotics to confirm the same. So the recommended screening antibiotic for autoimmune Addison disease, anti-21 hydroxylase and anti-17 hydroxylase antibody, which you are not doing in our CMC. For autoimmune thyroiditis, anti-thyroid peroxidase antibody, TSH receptor antibodies, and TH stimulating immunoglobulins. For type 1 diabetes, GAD antibodies and anti-islet cell antibody. For celiac disease, anti-tissue transglutaminase antibodies. But celiac, these antibodies to be considered only if the patient is less than 20 to 25 years. And pernicious anemia to screen, we have to send the anti-parietal cell and anti-intrinsic factor antibodies. So based on these, we have sent for our patient, we have sent these antibodies. Adrenal antibodies not available, so we have sent pernicious antibody. It came positive. Anti-thyroglobulin antibody, thyroid peroxidase or anti-thyroid peroxidase antibody also came positive. But anti-GAD antibody is less than 10%, less than 10, which was negative. But anti-islet cell auto antibody is awaited. But we have considered that based on the autoimmune polyglandular syndrome, if the 2 out of 3, that is our patient have Addison disease, our patient has a thyroid, Hashimoto's thyroiditis. So we have confirmed it is a, even though we don't have anti-adrenal antibodies, it is a probable autoimmune polyglandular syndrome type 2. The importance, and we have started the patient on prednisolone and fludrocortisone. So the significance of diagnosing autoimmune polyendocrine syndrome is, so here this patient we are planning to do HbA1c on yearly basis, because they will land up in developing type 1 diabetes mellitus within 2 to 3 years. And nowadays the recent trials are working on to develop a immunotherapy to prevent the development of the type 1 diabetes mellitus in APS type 2 syndrome. And the second importance of considering APS diagnosis is, if you consider treating if you diagnose a patient as to have hypothyroidism, and you started to treat, if the patient is having a underlying adrenal insufficiency, if you don't recognize that, if you don't screen for adrenal insufficiency, then treating thyroxine supplementation will have a detrimental effect. And also, so in all this patient who have a suspicion of APS syndrome, we have to rule out adrenal insufficiency before treating the patient for hypothyroidism. Thank you.
Thank you, Dr. Lakshmi. We have maybe time for one question from the floor or online attendees. Anyone? Yeah, Vinay.
Abortions, what is it?
Actually, retrospectively, I'm just linking that many articles have reviewed the effect of APS syndrome in pregnancy. They have mentioned that there will be occult adrenal insufficiency. It will start to appear from the 20 years of the age. It will cause more hyperemesis gravidarum. It will cause spontaneous abortions, but still there is no detailed article published. There are only some 3 studies published, and it showed that there is an effect of APS syndrome on pregnancy. It will cause abortions, but the thing is, the primary ovarian insufficiency occurs before the cortisol and type 1 diabetes to develop.
Thanks, Dr. Lakshmi. We'll move on to the next one.